Can start.
35-year-old male patient presented with a chief complaint of flank pain off and on for the past 3 months.
Sir, I would like to know the character of the pain, whether it is dull aching or constant or intermittent, whether it is mild.
Go to the next slide.
Move to the history of presentation. So, to elaborate this history, we have a 35-year-old male patient who presented with left flank pain on and off for the last 3 months. It was insidious in onset, dull aching in nature, radiates mainly to the back. The intensity of pain is mild to moderate, no specific relieving factors. However, the patient had a history of taking some analgesics for relief of moderate pain. Other than that, there is no other significant history, no history of burning, micturition, or any urinary symptoms, hematuria, pyuria, lituria. There is no history of fever. There is occasional complaint of nausea associated with the pain, and there is no other significant history like weight loss or any other comorbidities. Patient does not have any known history of renal stone disease in the past.
Sir, based on the history, that patient is 35 years with complaint of pain in the left flank, which is mild to moderate intensity, with no any history of lower urinary tract symptoms. I would like to put up my first differential diagnosis as the renal stone disease, sir. And
can you hear me?
Yes, yes.
Yeah, don't get into this habit of repeating the history. We've just heard the history. Why do you want to repeat the whole thing? You tell us what you think and what you need further.
Sir, the differential diagnosis as per the history would be, sir, the renal stone disease. The second probable diagnosis would be, sir.
See, the history is not at over. Whatever, finish all the history before you. This is only presenting history, past history of presenting illness. Anything more? Finish all the history, then come to the differentials. Anything more you want to ask in this patient?
Sir, is there any history of trauma in the past? Or is there any history of tuberculosis in the past, or any family history of tuberculosis? I would like to know, sir, in this patient.
Anything? Yeah, finish. Any surgeries?
Yes, sir. Any instrumentation or any surgery has been done earlier in this patient?
Yeah, nothing is there, right? Okay, fine. Now you said one is stone disease. Next, what are the differentials? Quickly.
Sir, the second would be, sir, uretropelvic junction obstruction, sir. Or third could be, sir, GUTB, sir. Little rare, but still can be put, sir. And these three differences could be, sir.
See, again, classify your answers so that you have told one is stone disease, one congenital PUG obstruction.
Yes, sir.
And what else you said?
Sir, GUTB, sir.
GUTB with nothing to say about lower tract. There is nothing to say weight loss, appetite, contact in the family. Simply putting one diagnosis is not. What else is common at this age?
Some cystic diseases, or congenital cystic diseases.
So usually they should be bilateral. Very unlikely, unless which cystic disease is presents unilaterally. No, there is condition. I just want to know because you are putting your differential.
Generally, it is bilateral only, sir. Generally, sir, ADPKD.
No, I know, but there are conditions which affect unilateral. Congenital conditions, cystic conditions which affect unilaterally.
Sir, medullary, no, sir.
Anybody? Renal cyst. You are listening or where are you? Congenital cystic diseases which affect only one side. Wow. You will be given gold, man. Gold medal. Anybody? What is medullary cystic disease? MCDK. Multicystic dysplastic kidney. Yeah. Is that affecting one kidney or both the kidney?
One kidney.
So you put your differential diagnosis. So when you give something rare conditions, you will be unnecessarily be caught. Anyhow, it was not required. But MCDK is one of the causes which affects one side kidney as a congenital cause. Of course, the kidney is not functioning. Sometimes it can become become large and all that. Anyway, okay, fine. Then, any other condition you want to put it?
Sir, renal cell carcinoma.
Malignant lesions.
Yes.
It may be renal cell or whatever. Malignant lesions, including adrenal as a rare cause.
Yes.
Fair enough. So in your differentials, you have to give congenital, stone disease, infective, malignancy. So if you speak in that way, most of your differentials will come into that. Rarely it may be something else. Now you are told PUJ also. Okay, next. So examination, we'll proceed.
BP is 110/70, pulse 98, no pyloric cyanosis clubbing or edema. Per abdominal examination, there is no significant findings. Systemic examination is normal and external genitalia findings are normal. So no specific findings on examination.
Sir, the examination is normal, sir, so would like to go for the lab investigation, sir. Blood routine and urine routine examinations.
Okay. Basically, you want to do an ultrasound and then, blood, urine, ultrasound, and then see what next.
Yes,
Basically, as of now, it looks more. So again, coming back to the history, he said, on and off pain, mild, dull aching. Does it fit in with the stone disease?
So it could be a renal calculus disease. It could be there, sir, because there is dull aching pain in renal stone, sir. So it could be the reasons. Unless until it get into the ureter where it will be colicky pain, so renal stone could be intermittent pain.
Yeah, fine.
So these are the investigation findings.
The blood investigations are within normal limit only, sir, and the urine routine examination, pus cells are present, sir, 6 to 8, and rest everything is normal, sir.
So something like sterile pyuria?
Yes, sir, might be, sir, sterile pyuria.
Yeah. For that you need at least 2 to 3 samples, not just based on one sample. Anyhow, so fair enough. pH is little bit on the higher side.
Yes, sir, little times.
Okay. Right. Next, what do you want?
Sir, I want to ultrasound abdomen.
Okay. There's nothing here, right? Okay.
Sir, the ultrasound pictures showing, sir, both the kidney are normal. Renal outline is normal, sir, and parenchymal thickness also normal. There is no any hydronephrosis seen, sir. And sir, in the left kidney, sir, one echogenic shadow is seen with the fusion of lower pole of the both left and right kidney, sir. And so this fusion part is little medial and anteriorly to the vessel, sir.
Yeah, we will not be able to understand what the sonologist wants to say. This is renal fossa, but I think he's showing the left kidney. There is spleen there, but no kidney.
Yes. Yes, sir.
So if I understand, then it's something like an ectopic kidney moving from left to right side. I don't know. We'll have to see the report then. Okay, any abnormalities other than fusion abnormalities, anything else? Is there in the previous image?
Orientation of the kidney is also, the axis is not normal, sir.
Okay, any abnormalities other than that position and this thing? Come back. What is the other image? Left kidney? That's all. Okay, yeah. The liver is seen and then. Okay, no hydro, nothing on this side. Yeah, next. Yeah, empty fossa. That may be some parenchymal calcification. Okay, right?
Sir, the right kidney is normal and corticomedullary differentiation is maintained. No calculus or heteronephrotic changes. The left kidney is small in size, measuring 70 mm length and seen just anteriorly to the abdominal aorta, with malrotation of long axis and fusion of lower pole. Calculus measuring 10 mm in the upper calyx, corticomedullary differentiation is maintained, and pelvic calyceal system not dilated. So it's a fusion of the lower pole of both right and left kidneys. Based on the findings, it's most likely looking like horseshoe kidney, sir. So I will be needing, sir, CT images to confirm the diagnosis.
So you want a plain CT or?
Sir, CT plain with contrast, sir, because echogenic shadow is also seen in the left kidney, sir. So I will be needing both plain and contrast images, sir.
We have it?
That is a very inadequate answer. If you are asked for a CT scan, there are various ways we can do a CT scan. So which CT scan would you order? CT with contrast is something we order for the abdomen.
Sir, multi-director CT scan, sir.
Pardon me, repeat that.
Yes, sir.
Repeat that answer.
Sir, MD, multi-detector CT scans.
Multidisciplinary CT scan.
It's obvious he doesn't know what he's talking about. Could somebody else help him out, please?
CT, man, 3 phases are there, no?
Yes, sir.
So why multi? Just say triphasic CT. That's all. You must know what the phases are.
Yes.
Actually, it should be called quadriphasic. What do you say, Manish? It should be called quadriphasic, not triphasic.
Yes, sir.
Unless you put that word in, our radiologist will not give you the last phase. They'll keep all the images with them.
Yes. So when we order, we do not order a triple phase CT in all patients. For this sort of a patient where we are evaluating stone and we want to see only the pelvic calyceal system, we would order at least what we call a CT IVU, which means a non-contrast, and then delayed images only, so that we can see the pelvic calyceal system.
Do they give you a different rate for it?
Yes, sir.
Oh, right. Anyway.
But that is also because we can directly talk to our radiologist, right? they are not immediately accessible, it would probably be better to order the same thing in every patient.
Yeah, I think if you talk to the radiologist, by and large, most things are done. It's just that sometimes patients come with their CTs from somewhere else, and that becomes a bit of an issue.
The other thing is most of them are done by radiographers.
Yeah, absolutely right. All radiographers.
The report is done by the radiologist later. They will see the patient and the images later.
Okay, we won't go into the phases, but everybody is expected to know how a contrast CT is done. You are expected to go and see how a contrast CT is done, and of course, read about it. So, go ahead.
Starting from how much contrast is given and what is the timing of each phase. All right? This has been discussed ad nauseum here, so don't waste time on it. Carry on.
Next slide. Next slide. Next slide. This is a plain plus contrast CT images of abdomen and pelvis. In the plain axial film, the right kidney is somewhat lower down in position with normal renal outline, parenchymal thickness normal, no calculus or seen no hydronephrosis, and little bit the right kidney is anteriorly rotated, and the lower pole of the right kidney is fusing with the lower pole of the left kidney, and the left kidney is small, contracted, small, sir, and sir, one radio opaque density seen in the left kidney with parenchymal thickness is decreased, sir, in the left kidney, sir. Sir, in the contrast images, sir,
in a plain film, you will not be able to tell lower pole, it is fusion, this, that, and all. It is not possible. You don't know whether what you see, is it a kidney or something else, unless you see a contrast image. You are describing the plain film. So you tell there is some shadow there. That's all. How can you say that it's a kidney on a CT scan without a contrast? That what you see as calcification may be a calcified lymph node or something else.
Okay.
Actually, your description also was not absolutely correct, accurate. You started off by saying that the kidney, the contour is all right. If you look at the top 4 films on this particular screen, you will see that while the extreme left shows the kidney in profile, but as you see the films, you see that the lower lip, the so-called at the hilum level, it seems to be projecting upwards. And then you see the next film, it is going across, right? Right up to the so-called IV. So you describe everything. You already said horseshoe kidney. That is why Dr. Prabhu took umbrage. He said, how can you say that? You describe first everything. We keep telling you guys, describe the X-ray, don't give a diagnosis. Unless it's an OSCE type of an exam. You learn to describe the X-ray. See how the radiologist gives the report. And then you slowly work your way around and say, okay, this is what I can see now. It's going across onto the level of the midline. And then can you actually see something else from the other side coming up? Then you go see the contrast images.
So the lower pole of the right kidney is projecting upward, and it is getting fused with the lower pole of the left kidney, sir. And in the contrast image, sir, the corticomedullary difference.
Okay, next row of images.
So in the contrast images, the corticomedullary differentiation of the right kidney is maintained with normal uptake and excretion of the contrast. And sir, the obvious fusion of the lower pole of the right and left kidney with a thin fibrous band in the midline that is presenting anteriorly to the great vessels, outline vena cava, sir. And so there is no, in the left kidney also the corticomedullary differentiation is maintained. Mild hydronephrosis is there, sir, with one radiopaque shadow, sir, in the left kidney upper pole region, sir. And there is no any aberrant vessels seen, sir. Normal excretion of contrast, sir, in both kidneys.
How will you say that there is no aberrant vessels, man?
That there is no any other vessels seen projecting from the aorta, sir, or...
Yeah, for that we'll have to go back to our first question. That have you seen all the phases of the CT? Do you have all the phases? Are the images adequate to comment on that? So if you have only a few hard copies, making statements like that may be very difficult. You need a full study. And in a horseshoe kidney, would you expect aberrant vessels or would you not expect aberrant vessels?
Then we will expect, sir, aberrant vessels.
Okay. So was that your objection, Prabhu?
I mean, you want to see a vascular phase, and only then you can say whether there are abnormal vessels. And it is expected in the case of horseshoe kidney. And to make a statement there are no aberrant vessels, you should be a little careful. You can say I am unable to appreciate because there are no proper phases and not many films are there. These vessels may be very small, and you should not make a statement like that.
Yes.
You are very sure that the corticomedullary differentiation of the left half of that kidney is normal. Eh? You said it's normal.
Yes, sir.
You didn't comment about the size. It's all.
Side of the left kidney, it's small in size, sir.
So if the left kidney is small, how is its function? You compare the left and the right sides.
Yes, sir. The left is smaller as compared to the right side.
No, you look at the contrast density in the right kidney and then in the left kidney. Are they same?
No, sir. In the left kidney, somewhat the contrast uptake is little less than the right kidney.
Avoid using this word little. Use terms like reduced uptake, mild reduced or whatever, but little and all is not correct.
What is that white blob? That white blob is there. Yes. What is that?
So it could be any calculus, sir.
Did you see it in the plain film?
Yes, sir.
You saw this in the plain film?
Yes, sir. It was there in the plain film.
Really, let's have a look. Oh, we didn't see these images, man. Okay.
Can we go to the reconstructed images? on the left lower image, if you are given only this film, will you be able to tell me that it's a horseshoe kidney?
Yes, sir. We can say that because the lower pole of the left and right kidney, it's coming more medially, sir, and fusing with the left kidney, sir. So,
Is it the lower pole or something else? Of course, if you have a IVU of this patient, I can't see the hole proper, but I can see the something else.
So this is a reconstruction of the delayed phase where you're seeing the pelvic ileal system, which is what you would see on an IVU. Now, if you're given an IVU image, what would be the finding that would tell you that this is a horseshoe kidney? Anybody could help him out, please?
IVU findings in a patient with a horseshoe. What is so difficult?
The flower vase appearance.
Where did this come
What
from?
types of flower vase is available in the world?
What will be the level of the isthmus? What will be the axis of the calyx, lower calyx? Which it will be directed to which side? That will be, you will be able to answer that. You are seeing all that, but you are not able to describe it. Where will be the PUJ?
so the isthmus will be at the, sir, L4, L3, L4 level, sir.
So please remember that you will not see the isthmus because usually there's no collecting system there. Very unusual. What you do see is a kidney which is lower down. You mentioned it in your axial description that the kidney is lower down as compared to normal.
Yes.
The axis of the kidney is pointing outwards, not towards the rib, if you draw a line from the lower pole to the upper pole. And what Prabhu is trying to tell you is that the medial calyx is very obviously seen in this lower image. And where is it pointing? The lowermost calyx. Is there a calyx which is pointing medially?
Yes, sir.
Yeah, so these are very obvious findings suggestive of horseshoe kidney. And IVU findings of a horseshoe kidney, again, one of the things you should be able to vomit it out whenever asked.
Why is this kidney low placed?
Sir,
Why is this kidney low placed?
sir, because the ascent of the kidney didn't take place because of the it gets arrested due to the inferior mesenteric artery, sir. So the ascent of the kidney doesn't take place during the developmental period.
Right, okay.
Is stone disease in horseshoe kidney more than general population?
Yes, sir. Due to the stone is more so in the horseshoe kidney because there is obstruction in the drainage pattern of the kidney and also increased predisposing factor for.
This is a catch question, all right? This is a catch question by Prabhu. Catch question. The incidence of stone disease in horseshoe is no different to what it is in standard kidneys. So don't think that just because the kidney looks a little different that the incidence of stone disease in that would be higher. No, it's not the same.
Sir, there are some newer reviews which do state that the incidence of stone disease is higher in these patients.
Is it?
Yes, sir. Yes, sir. I mean, we've all read it for a long time that there is no difference, but now there are some reviews which state that it is a little higher.
Then I stand corrected. I need to read those reviews.
Yes.
Sir, the evidence is mainly because the lower pole of the horseshoe kidney is not brilliantly drained like a normal kidney. Since the lower pole especially is much more dependable, the chances of clearance of small stones at small stage is very less, so they stay and become larger. That is one of the physiological or anatomical factor which results in increased stone incidence. Otherwise, if you say...
But Anand, lower pole of kidney is anyway in a normal kidney also the commonest site.
Yes, sir.
Because
But
it's not dependent.
yes, sir.
That argument is not true for horseshoe specific.
Sir, but here that infundibulous pelvic acid angle is much more obtuse, making the like a flexi-URS also challenging and the anatomy also more in favor of stasis. But at the same time, surgery-wise, PCNL or ureteroscopies are almost equivalent, or there are articles to prove that surgery is easier in horseshoe compared to normal kidneys.
Anyway. Right, okay, proceed.
So what do you want to do? Let us know now. Are there any more slides?
What? Shubham, do you think this is a PUJ obstruction or a stone causing obstruction?
So it's not a PUJ obstruction, sir, because there is no any hydronephrosis seen, sir. It's mostly due to the stone present, which is no, sir, no PUJ obstruction, sir.
So we have to manage this patient eventually, no? We have to tell him what to do.
Sir, the patient is since the stone size is little big size in
Again, I told you little, you are a little,
yes. The stone looks bigger in size.
It's a stone which is 2 centimeters, 2.5, whatever said. Use a figure. And say because of this size, this is what I would like to do. Full stop. Fellas.
The stone looks bigger in size, sir, on the CT images, sir. So I would like to proceed with PCNL in this patient, sir.
You think the density of the stone is high?
Yes, the density is also high, sir.
So
you said PCNL, man. Can you see some structures by the side of the kidney? Before you reach the kidney, will you be able to puncture it? How will you puncture? You are not, you are only looking at the stone like Arjuna, or you are looking surrounding areas?
Yes, sir. We will look the surrounding area also, sir, because there, since the kidney is lower down, so we will mostly colon will be so retrorenal colon will be we will sir, notice, sir. So we will have to do puncture either USG guided puncture we can do, sir, in this patient, sir, so that we could be safe while puncturing.
You have an imaging which is better than an ultrasound right in front of you. Can you describe the upper middle image and what is the problem in accessing the left kidney?
So on the left side, sir, the descending colon is visible, sir. So it will be difficult for the puncture, sir, but still we can because since the
where is it visible?
In the second image, sir.
In the second image, in relation to the kidney, where is it visible? What is the term to be used?
The retrorenal colons.
Yes. So does it look like a retrorenal colon here, at least in that image? Anyway, I think the point Prabhu was trying to make is you have to look at these factors. Where is the spleen? Where is the liver? Where these are in organs which do get injured, and definitely if the bowel is retrorenal, you would not. There is no ultrasound which will confirm the bowel is not retrorenal. If it is seen on a CT, you will probably have a different approach.
See, this image is very clearly depicting the factor of PCNL technique in horseshoe kidneys. If you look at that shadow, normally you would be puncturing from the side, or that window, and you would not have the other structures, the other organs which are seen here, the spleen and the colon, etc. So if you look at this stone, and if you want to hit a window, you'll have to go through just by the side of the paraspinal muscles or through the erector spinae. That's why the puncture is very, very medial in a patient with, when I say medial, I mean in the prone position, it will be literally very close to the spine, and therefore it will be going actually through the erector spinae. If you draw this line from posterior there, you will find it going through there. That's the only place. So therefore you will have to go through literally by the side of the paraspinal muscles to hit that. And the depth also is significant in these patients. So you need to be cautious about doing PCNL in patients with a horseshoe kidney. So once you put contrast into that collecting system, you will see where it fills up.
Okay. So just 2 more words about PCNL in a horseshoe kidney. You go through the upper pole, and because, like Sir said, you go through the erector spinae, your mobility of your amplats is very limited. And unlike a normal PCNL, you will not be able to move your scope around too much. Now, is this confirmed that this shadow is a stone? On ultrasound also they had said a stone, right?
Yes, sir.
Okay. Now my objection is to your decision for a PCNL completely. Would you like to change track and think of something else?
Sir, kindly repeat the questions.
I am objecting to your decision for a PCNL.
Okay, sir.
In this patient.
Sir, stone disease in horseshoe kidney can be managed with other maneuver also, sir. But since the stone size is bigger, sir, so PCNL will be the treatment of choice in this patient, sir. But still we can go with flexible ureteroscopy, sir.
I am objecting to your decision for stone removal.
So, are you planning to remove a 4.7 centimeter stone by RIRS?
No, sir. In multiple sittings we can do, sir. Not in one sitting. In multiple sitting.
Your exam is having, 3 papers, theory papers, like that. You want to do in 3 sittings, or the examiner will tell you come in 3 sittings. See, you have a kidney which is lesser functioning. You have a stone which is very large. 4.7 is quite a large stone. It's not a small stone.
Yes.
You will have to sit with that. Even if you are doing PCNL, you will have to sit for about 3 hours, breaking the stone, removing the stone. So that's what Dr. Manish is asking. Do you want to rethink on what you said, PCNL?
You go back on the CT scan and tell us about the functional status of this kidney. You said it is small. What is the function? All those things you'll have to decide. Sir,
since the kidney is small, sir, left kidney is small, and the contrast uptake is not so good, sir. So we will do a DTPA renogram to see the functional status of the kidney, sir. And if the functional status of the kidney is not good, then we can opt for left side nephrectomy, sir.
Do we have a...
You didn't want to think of this suggestion before?
See, if you see the left side, the lower image on the middle one, the lowermost, you are seeing some drainage across the ureter. Function is good. Now, DTPA will not be, it's a good image, it's a functional study. whatever the contrast, you don't need to quantify it. GFR must be about 20 to 30 in this case. Even though the kidney is smaller in size, the function, there is drainage across the kidney. So I won't agree that you are planning for a nephrectomy in this case. And that too, when in a patient who is young. Second, there is no infection. And, so nephrectomy is a little radical step.
I want you to argue with that statement.
Though the excretion of the contrast is seen in the left kidney, but the size of the kidney is small, and sir, in the CT images, the contrast uptake is not so good, sir. So I will like to do DTPA to see how much function the kidney is working, and based on that, I would like to proceed further.
See, there is one more feature. There is one more feature on the CT scan which can support your theory of doing something different. You look at the size of the right kidney. The right kidney size is significantly bigger when compared to the left.
Yes, sir.
So which would indicate to you that some degree of compensatory hypertrophy is occurring on the opposite side. It means that the kidney on the left, yeah, it is draining. There is some contrast and it's going down into that urine. It's not zero. But you have to argue. What Dr. Manish was trying to find out from you is whether you want to argue your case out or not. There is no right answer and wrong answer in a situation like this. Some people will take out the some people will take out the kidney. That's between the surgeon and the patient. The patient then decides what he wants to do with his kidney. Surgeon has decided. Whatever he decides, the surgeon, if a complication happens, that's his on his head, that's all. So that's a decision that he makes. This is a class. So we want you to think about the possibilities and why A or B has made these decisions, that's all. Surgeon A may say, I would like to do nephrectomy for this particular reason. Surgeon B will say, I will do PCNL for this reason. Both are right. So you as a resident must know both sides of the coin and decide as to how you will defend your decision. That's all.
Sir, in this condition, sir, we can go for PCNL, sir, and after the surgery, sir, through the PCN, we can see the urine coming through the PCN. We can calculate the specific gravity, and based on that, we can also detect what is the function the kidney is working. And if the kidney is not working properly, then after PCNL, we can also plan, sir, nephrectomy, sir. So we can give a chance to the patient by removing the stone, and later on we can decide based on the PCN drainage output, sir.
Why do you want to remove? You removed the stone. Why do you want to remove the kidney? Your decision was to remove the stone. You removed the stone. So why you want to give a chance now to remove the kidney? Second, 2 operations you want to do.
Sir, after the stone, there are conditions. After the stone removal, some kidney function may improve, sir. So,
okay.
Sir, so after the removal of stone through the PCN side, the urine, we can calculate the specific gravity. And
how long you will keep this PCN, man, after the stone removed?
For 3 weeks, sir, we can.
3 weeks? Why? Is that what you do? After removal of the stone, you have decided to remove the stone. First, that's your decision. If you decided that I want to preserve this kidney before you remove the stone, then that's not the way to approach it. You understand the logic, Shivu? You have decided to remove the stone. Now you are keeping the PCN for 3 weeks after that. What is the reason to do that?
We can give a chance for the kidney to.
It may take much longer than 3 weeks. You don't know. The argument is, if you have decided that you want to preserve this kidney, okay?
Yes, sir.
If you have decided that you want to preserve this kidney, then there's a logic in putting a PCN tube for whatever reason you want to, and then see what happens to the creatinine clearance, whether it has improved at all or not, and then decide. But to me, it seems a little strange that you want to take out the stone, leave the PCN for some time, 3 weeks and for whatever time, and then decide. That's not the way you work. If you have decided to remove the stone, you remove the stone, full stop. And then you follow up this patient and decide whether this kidney needs to be nephrectomized later. The indications for nephrectomy in that kidney would be what? Not because it has lost its function. There are so many people with poorly functioning kidneys which have not been removed. There must be an indication, and what are those indications to remove that moiety, if at all, after the stone is removed? Tell me, under what circumstances will you remove that moiety after removing the stone?
If the creatinine clearance is poor, sir.
That's not the reason.
If I am following up this patient, Dr. Anand had stated what happens in these kidneys. So there will be stasis. What do you expect will happen in that portion of the stone? Of the kidney, sorry. In that portion of the kidney, if the patient comes back after a year, what would you expect?
See, only three things will happen, Manchego. Either it will improve its function, or it will deteriorate, or it will remain the same. Only three things are possible.
Yes.
Isn't it?
Yes.
So you remove the kidney just because it is remaining the same function or reduced function? You remove it? Is that the indication for removal?
So what are the two more things that can happen? You forget about the function. What other complications can happen? If you intervene in an obstructed kidney and leave it obstructed, what do you expect will happen?
The increased chance of infection, sir.
So one, if there is recurrent pyelonephritis in this kidney,
Yes,
you
sir.
would think of a nephrectomy. What else can happen in this kidney?
The recurrent stone formation, recurrent infections, and this kidney are more predisposed for malignant changes also, sir. So there could be some malignant transformation.
Hey, why, man? Huh?
Because of recurrent infections,
See. No, nothing like that. If it's a Staghorn stone which is there for 15 years, then squamous cell changes are described. So don't scare the patient by putting, it can become cancerous. Huh?
yes.
Your OT list is free, so you don't scare the patient and put it like that.
So rather than putting in a PCN and waiting, how I would have argued is saying that the opposite kidney suggests compensatory hypertrophy. This kidney is unlikely to be functioning well. If I do take out the stone, it is only going to recur. PCNL appears to be very difficult. RIRS is probably impossible for such a situation. So we would have to think of open surgery. And considering everything, I would prefer a nephrectomy as compared to a stone removal. However, all this would have been much better quantified if we had done a nuclear study and quantified the function of this kidney.
So that fellow is coming today.
Okay.
So have we done a nuclear study?
No, sir. Nuclear study has not been done.
See, there is in congenital abnormalities. Remember that some kidneys are known to be small. There are conditions where one kidney is, let's say there is no stone, nothing. One kidney without any infection, congenitally they are small, and that condition is also there. So just because the size is smaller in a congenital abnormal kidneys, so we cannot say that this is not functioning. As far as that delayed image in IVU is seeing, it is showing good function. So
Yes,
better would be open surgery. You can tell, I will go and remove the stone, and if the kidney is looking better, then we will preserve it. So there's no harm. You can talk to the patient, discuss, and say that if the kidney is looking very bad, adherent, and it is sometimes there can be infection in that which you may not get it in a urine culture. Sometimes there can be pus, rarely. In such situations, you may decide and remove it. Otherwise, maybe you can just remove the stone and tell the patient, this is abnormal anatomy. We will follow it up. If the function is well preserved and there is no infection and your pain is relieved, we'll follow it up. Otherwise, you may need a second surgery at a later date, which may be a removal of the kidney.
So I agree with Prabhu, and I tell you, go ahead and do a pyelolithotomy. What would be your reply to that? Open pyelolithotomy.
Yes, sir. It will be a better option, sir. Open pilot.
That was not his question. His question was, he has taken the decision. Now you have to do it. So how will you?
Would you come back and object to my decision? Is my question. We have agreed that you will remove the stone. We have agreed that you will do open stone surgery. In open stone surgery, I have asked you to do pyelolithotomy. In any kidney where you have to do a pyelolithotomy, what is the precondition?
If you open
anybody else?
If you open the pelvis,
Yes.
in a pyelolithotomy, then you close it, isn't it?
Yes, sir.
What happens if it continues to leak urine? Even after you close it, it's not again urine is leaking from the drain. What could be the reason?
Could be the closure would not be watertight.
Closure was watertight. Closure, you did your best, but water will find its way, man. How much of a tightening you put? You cannot, all the dams burst like that only, man. We have done all sorts of rubbish with the dams and still they burst. You can't fight with this. I'm trying to give you a hint to answer Manish's question. Again, these are basic principles of surgery. A fistula will not heal if there is what?
There is some foreign body is there.
A fistula will not heal if there is
infection, sir.
Distal obstruction, Baba.
Yes.
When we joined MS General Surgery, MBBS, we were told this. All fistulas will not heal if there is a distal obstruction.
Yes, yes.
As a result of that distal obstruction, you can get various types of infections, this, that, all that. That comes secondary. But you have to clear the passage first. So that is why Dr. Manish asked you, what will you do if you are this pyelolithotomy business you want to do? Will you ensure something else?
We will ensure, sir, is there any disturb?
No, especially in a kidney which is horseshoe.
We will ensure, sir, is there any other distal obstruction and any.
Okay, you will ensure that the PUJ, not distal. The PUJ is the one which is in a compromised position in a horseshoe kidney, and you want to make sure that that is not the reason for this fellow stone or problems, etc. Okay?
Yes.
Is this stone in the pelvis?
Yes, sir.
What are the other approaches you can take for a stone with in this sort of a situation? Or in any stone, other than pyelolithotomy, what are the other open approaches for a stone?
Sir,
The ultrasound had said,
rephrase that question, Manish.
okay, so the ultrasound had said that this is an upper calyceal stone, suppose 4 centimeter upper calyceal stone. The rest of the things remain the same.
Yes.
So now, is there a different approach? Now, another stone which is almost a complete Staghorn. So is there a different approach for that? All for open surgery, I'm asking.
So we can do nephrolithotomy.
So for a dilated upper calyx with a 4 centimeter stone with thinned out parenchyma, where would you make a renal incision? On the parenchyma? Where would you make it?
The Brodel's line, sir.
How did you identify Broden's line?
So it's just lateral to the lateral on the posterior.
This is a horseshoe kidney. Aberrant vasculature. You don't know the vasculature, so you don't know the Brodel's line. Even otherwise, yes, okay. One of the ways to approach a large Staghorn is through the Brodel's line, but it's whoever has done it will tell you that it is not a surgery that you can take lightly. Is there a simpler way of taking out an upper calyceal stone in a dilated upper calyx?
No.
Anybody else? Why can't you replicate a PCNL in open surgery, make a small radial nephrotomy and take out the stone?
Yes.
Okay, so you have told us 3 approaches. Now, is there any other approach for a large Staghorn stone with in the pelvis? Have you heard of a gentleman called Gilles Vernet?
Yes, I heard the names.
Can anybody tell me what is done in that operation? Final years, anybody?
So the plane between pelvis and parenchyma we approach.
Yeah, that was the subadventitial plane which you saw the other day. But what do you do there?
Disconnect the pelvis from the parenchyma.
Okay. No, we are wasting time here. Please go and read open stone surgery. We know you do not read open stone surgery, which is why these questions are being asked. You cannot do a pyelolithotomy for every stone. You have to go and find out what are the options for open stone surgery. And believe me, someday some general surgeon is going to call you for help in an open stone operation, and you better know what is to be done in that situation.
Yes.
So what was done, Frankie? Or not at operation?
Where is this case from?
Sir, this patient has gone home, sir, and to come back, sir. He is just advised given.
What advice is given?
Sir?
What advice is given?
No, sir, we had given advice for PCNL, but he is yet to come back. We have given him for both PCNL and open surgery. Both of them has been counseled to the patient, complications and all, but he has gone home for some financial issues, and he was from different state, so he will be coming back, I guess.
Right.
But we just had the case, that's why I gave it for discussion, sir.
Very good. Very good.
Good. Thank you, sir.
Okay, thank you.
Thank you.
Thank you.